For the introduction, and to Link, thank you for the invitation. Hope everybody in Spain is well in these difficult times. So I put a little presentation together called Zones and Cones, and it's a reflection on part of my philosophy and part of the work I do with revision knees in Cardiff. And I hope it entertains and hope we can all learn a little something, and I'm looking forward to the questions later. So today we're going to look at zonal fixation. It's now, I think, an established principle. And then we'll look at how trabecular link, tibial and femoral cones work nicely with the zonal fixation philosophy. And as I say, I'm happy to take any questions on anything I say today. So we published on zonal fixation some 5 years ago. And I think we can all establish that it's, I think, useful for revision knee surgeons. And we look at three zones: the epiphysis, the surface, the metaphysis, and the diaphysis. And the metaphysis historically has been the zone that we ignore. We go straight from the surface to a big stem. But then we miss out on a big piece of bone that can help our fixation and our reconstruction. And we talk about trying to get fixation in 2 out of 3 zones. So let's go through that in a little bit more detail. Because if you don't get good fixation, your reconstructions fail. And here's an example from a few years back now where I was sent a patient with no cement in the, or a little bit of cement in zone 1, almost nothing in zone 2, and stems that were too short and too narrow in zone 3. So at all 3 levels, all 3 zones, fixation was inadequate. And as you see from the X-ray, failure was inevitable. So when you think about zone 1, it's the surface after you've done your primary cuts. At revision, we're trying to establish a stable surface with a flat cut and augment any defects. But once you've done that, your only fixation option in zone 1 is going to be cement. You may want to supplement it with a stem, but fixation in zone 1 is by cement. In zone 3, you have 2 good options. That all depends on your bone quality. You can go for uncemented stems or cemented stems. And in my opinion, they both work if you choose the right implant for the right patient. Zone 2, the metaphysis, is really what we're going to concentrate on for the rest of this lecture. When you explant and you debride, you're left with a conical, tapered surface, and you need to reconstruct both centrally and peripherally sometimes. Your reconstruction options include sleeves, bone graft, cement, or cones. But fixation in zone 2 will only ever be by cement or by sleeves. But to get fixation, you have to be able to reconstruct. This is a series of X-rays from my colleagues in Exeter, and they've done a reconstruction of metaphysis of the tibia using impaction bone grafting and a metal mesh to reconstruct and contain the graft. Having done the reconstruction, they've then gone for good fixation with cement in zone 1 and 2 and a supportive uncemented stem through zone 3. So philosophically, this works very well. You've got good reconstruction and good multi-zone fixation. This is a case from my own series where an elderly woman had a poorly balanced knee replacement that led to massive polyethylene wear. And you can see significant lysis in the tibia and the femur and major bone loss laterally. But you can reconstruct and get good fixation. And in this case, I chose to use a sleeve to fix and reconstruct in zone 2. But because the defect was largely uncontained, I had to use a very large stem to give me secondary support. And you can argue whether that large stem was either necessary or may cause problems by itself. But in this case, by getting fixation and reconstruction and loading the bone, we see here the initial post-op X-ray, very little bone, that slowly starts to regenerate. At 3 years, you've got an excellent bone regeneration because you've got the reconstruction and the fixation working together. But to achieve that, I've put in a very large stem to support that sleeve. And I would argue that if you can fix closer to the joint line with possibly better reconstruction and a shorter cemented fixation, you may avoid the problems of long diaphyseal stems. So over the last 15 to 20 years, we've had cones available to us, and these are trabecular metal cones, and the ones I've used initially in some of my reconstructions. But remember, trabecular metal, all cones are for reconstruction initially. The fixation is going to be cement. So let me show you a case. Here's a gentleman who's had multiple revisions, multiple extensive reconstructions which have failed, and it's now infected. So I've chosen in this case to go for a two-stage protocol. I've removed everything. I've put in a static reinforced spacer to give him a straight, stiff leg, but weight bearing. And part of my thinking with deficient extensors was that maybe arthrodesis was the best option. And I put this in to allow him to weight bear and decide whether this was good enough for him. After 10, 12 weeks walking straight leg, he decided he wanted a second stage, but he wanted movement. So then I'm left with a difficult reconstruction option. What we did was choose a fixed hinge because of the extensor weakness, but use trabecular metal cones in both the tibia and the femur to give me reconstruction and to try and create two zones of fixation. And by that I mean, look, I've got cemented diaphyseal reconstruction. Zone 2 doesn't really exist, but I've put a trabecular metal cone in there to give me a second zone of fixation. And I've done the same above. So I've got good reconstruction, I think, and good fixation. And this patient is now out at 5 years with no loosening and thankfully no recurrent infection. So using reconstruction over two zones to give good fixation can, even in difficult cases, give you good outcomes. So trabecular metal has been around for a long time, and it was a great innovation in its day, but it's failed to evolve. It's been a static implant that really hasn't developed, and there are certainly problems with these single rings that can be an issue on table in terms of sizing, implantation, and the risk of fracture around often poor cortical bone. Thankfully, we do have some new innovative options. And I'd like to introduce the Trebulink cone, which has been on the market for a few years now, and I've had great success in using it. I'd like to show you some cases and show you some of the philosophy that I bring to using these cones and why I think it's slightly different to a trabecular metal cone from Zimmer. But both are reconstruction first, fixation second. What the Trebulink cones give you is a cone that's designed for cementation with a sealed in a wall that stops cement getting through to the interface with the bone. It's got a porous coating, rough, that allow you to get good interdigitation with bone. At the front, you've got this compressor, which allows you to impact into bone, but keep consistent circumferential stresses on the bone. I think the compressor really does make a difference because you can impact it in, and on table you immediately get the feeling that it's really well fixed, and you will produce hoop stresses all the way around by having medial lateral and AP elasticity compressing the hoop and giving you good fixation and constant interface tension, which I think should encourage bone ingrowth into the implant. This is the three-dimensional structure, the pore size, the porosity, and the structure depth. It's made of a titanium alloy, which again has a slight antibacterial effect, but also is very good for inducing bone ingrowth. Let me give you a case. This is a well-fixed sleeve implant, it's a Noyles. But the surgeon has failed to reconstruct the joint line, so the patient presents to me with a painful flexion contracture. If you look on the lateral, you can see there's a secondary baha. That's because the anterior joint line has been elevated. That's happened because we've got fixation in zone 3 and 2, anterioralizing, pushing the joint line up, and that leads to anterior knee pain and loss of extension. This was a good, well-fixed implant, but functionally poor because the patient couldn't extend and therefore couldn't walk on it. Explanting sleeves and well-fixed uncemented implants leaves even bigger defects. So you need to think about your reconstruction and your fixation while still trying to get the joint line in the right place. This is what we did. We explanted both. On the femur, I went for a simple cemented fixation. On the tibia, I've reconstructed with a cone. You can see laterally here, I lost quite a bit of bone stock explanting. We've got good reconstruction and cemented fixation through the diaphysis and the metaphysis. If you look at the joint line now on the baha, it's disappeared. That's because the joint line is now in the right place. Again, you can do that by fixing closer to where the joint line is, going for metaphyseal fixation rather than zone 3 diaphyseal fixation, even in re-revisions. And I'm pleased to say it's actually a very simple technique. Once you've made the hole, all you have to do is decide which size cone you want, tap in the trial to make sure it fits, and what level you want to sink it to, do your trial reductions, and then you can move on to putting the definitive in. And there's a very nice tamping system that will allow you to introduce it under with a hammer and mallet, but the compressor at the front here will close to give you constant tension all the way around that implant, and then you just cement through it. Very, very straightforward technique with good instrumentation. Let me give you another example. Again, well-fixed and cemented sleeve and stem, but with a lot of stem tip pain at the bottom. So again, if we're going to go back and reconstruct, we want to move away from distally loading uncemented stems to get fixation closer to the joint line in zone 2. And that we achieve again by explanting, reconstructing zone 2 with a trabecular link tibial cone, and then cementing through. So I've got a cement interface with the bone, a narrow stem below, and great fixation in zone 2 above. Again, this takes away the patient's pain, gives what they want, function and pain relief. So this slide is all about bias, and one of my biases is that I would never use a hemi-cone or a partial cone. I'll only use a full cone. And that's something I brought up from using TM cones originally, because if you think about it, you use these hemi-cones because you've got good bone stock here, and you've got very poor bone stock here. So normally good bone stock laterally, less good bone stock medially. However, if the worst bone stock is here, then you're going to get relatively poor fixation. So I would suggest if you've got good bone stock laterally, you want a full cone, because this is where you're going to get your best fixation. And this is an example here. Look, I've got no bone at all medially. I have bone posteriorly, anteriorly, and laterally. So that's where I want to use the porous coating. So I would always use a fully porous coated here, because I want to get that bone in growth laterally as well as posteriorly, and medially I'll accept there's no bone to grow in. So that's a personal bias, and I'm happy to debate that. Cones, whichever company you use, should, I think, be universal. So you can use them with, as in Link's case, every type of implant that they produce, but also you can use them with other manufacturers' implants, and you shouldn't be afraid to do so. Because there may be the odd occasion where you want to do a tibia-only revision or a femur-only revision. What you want are implants that'll be universally acceptable, give you reconstruction for you to use cemented fixation of the implant of choice. And I've done this with numerous other implant manufacturers, and it works well. But the big defect really is, or the big absence, femoral cones. Let me show you how I've been using cones up until recently. So this is a multi-revised patient with an infected revision, and I did this revision myself some 3.5 years earlier. And although he did well, he had a recurrent infection. But now I have major bone loss, and tibia and femur. I've got infection. I've already gone for sleeve and stem fixation. So I know when I explant this, I'm going to have even bigger defects. My choice was to go for a distal femoral replacement using a tibial cone in the tibia to reconstruct and give me zone 2 fixation with a cemented stem, and the same in the femur, where I've used a tibial cone upside down, impacted it in to give me a pseudo zone 2 in the femur. So I've got fixation just above the implant and with the stem above it. The white here is stimulant beads to help me introduce local antibiotics and control the infection. He's now out at 2 years, and at the moment, no recurrence, but with good bone interdigitation here and below, where you see the bone grow into it. And here particularly, you see good bony ingrowth into that implant. If only we had a femoral cone. Here's another case, an 82-year-old, several revisions, aseptic loosening. And again, I revise and use tibial cones in the tibia and the femur to give me better zonal fixation. And they work well. But can we do better? Can we get a better fixation in the femur? Because this is quite a short fixation for the femoral anatomy. If you could go a lot deeper, it would help. If you go a lot deeper, you may avoid the odd complication. As you can see there, I produced a little stress rise on the corner of my cone as I put it in, produced a little fracture. Didn't make any difference to my weight-bearing status or the outcome, because I've got good three-dimensional fixation with the cone and good stem fixation above. So I'm quite relaxed about that. But if we had a cone designed for the femur that was narrower and longer, you probably wouldn't see that sort of problem. The good news now is that we have these available to market over recent months. And I was lucky enough to help with the trialing of these implants. And Link flew me out to several cadaveric labs in Germany. And these are the image intensifying images that we took from, I think, a meeting in Dresden with Thorsten Gerke. And Thorsten, being a good German surgeon, impacted the sleeve in with great force. And I could not believe how well fixed this tibial cone was. I'll show you the, put in so hard. We produced a little crack down here. You probably can't see it, but there's a crack on the posterior cortex. But that sleeve, because the hoop stresses and the compressor and the porous coating, would not move. We could not expand it. I think the problem here was it was a trial situation, and we only had a limited number of size of cones, irrespective of the size of the cadaver we were using. But look here. We're now going from zone 2 into zone 3. So we're bridging zone 2 and 3. We've got long, tapered cones that are designed to fit the femur. If I compare the cadaveric X-ray to my post-op from I showed you earlier, you can see that although we've got a second zone here, it's quite short compared to what we can get with a designed femoral cone. The same on the lateral. We've got longer zones of fixation, and we're going from zone 2 to zone 3. Zone 2.5, we might want to call it. So again, we're thinking about how we're getting better reconstruction and fixation. To date, I've only done actually done 2 femoral cones. I did one before the COVID pandemic locked everything down in the UK, and I've done one since. So this is the one I did just before we locked down. Very, very well fixed femoral sleeves, but again, a painful fixed flexion deficit, could not fully extend, and therefore had no function and pain. But really well fixed stem and sleeves. And at explant, I again produced this fracture. This was explanting rather than implanting. Because we've got a long bridged femoral cone, we've bypassed that. With cemented fixation after a good reconstruction, I was able to get the patient up fully weight bearing day 1. And she's now out, I think 4 months, 3-4 months later, and doing well. Again, just to show, look, big zone of fixation, bypassing the fracture I created when I explanted. And if you've done a lot of explants and re-revisions, this is not an unfamiliar scenario. And again, on the lateral, the same. The second one I did only last week, and this was a multi-revised proximal femoral replacement for infection. And what I wanted again was as long a fixation as I could manage within poor bone quality. So I used a femoral cone low down in the tibia, and that conical shape was ideal for giving me a long zone at an area where there'd been poor bone stock and failed fixation before. And I haven't got the x-rays, but maybe the next time I talk, I'll have them available for you. So, trabecular cones. There are many manufacturers now who have cone systems. I've had experience of using the trabecular metal cone in the past, and I've been happy with it. But the evolution has stopped. What we now have with the trabecular cone is a very thoughtful evolution of what happened before. So we've got a cone that is designed for cementless implantation with a designed porous coating for bone ingrowth. We've got a sealed inner wall that won't let the cement ingress to where you want to get porous ingrowth on the outside. We've got a compressor in the front which allow elasticity, hoop stresses, and an immediate press fit with good tension circumferentially. I think all of these things are really good innovations. But what else is new? Well, just a couple of slides. This is the mother of all stems. This is a monster stem. It's called the OptiStem. And up until recently, it was only available as a custom made, but it's now available off the shelf should you need it. And the idea is that you have a very large, uncemented, there is a cemented option if you really want it. It's a large, uncemented, tapered stem with a special adapter to fit in with a family of linked distal femurs. I've never used it, but you know, it does make a lot of sense in young adults, high demand, heavy individuals. Here's an x-ray from the original custom-made implant that started the OptiStem story. So that's available for cases. And if you have major defects, then again, using the custom-made link system, you can use trabecular link cone technology to produce custom-made proximal tibial cones. And again, I've not used them, but these are intraoperative x-rays from and pictures from a case that has been done as a custom. So this also is available for even the most complex situations. So the trabecular cones gives you stability through an immediate press fit on the inner cortical wall. Compress will give you elasticity, so it'll compress to fit to reduce the risk of fractures and to give you hoop stressing to promote the interface and promote bone ingrowth. And it's versatile. You can use it with any of the link family and other systems if you want to. I'm convinced, and I use it regularly now. And I don't think I'd easily move back to other cone systems because of what I get with the new evolution present with trabecular cone. Now, I may be biased. I probably am. I'm open for questions. Thank you.